Thanks for joining us. I'm WTOP Capitol Hill correspondent Mitchell Miller, and this is the Healthcare Agenda, Real Policies for Real People, sponsored by Pharma on WTOP.com. And my guest today is Congresswoman Diana Harshbarger, who represents Tennessee's 1st District. Thank you very much for joining us.
Hey, it's my pleasure to join you today.
Well, you have worked as a pharmacist for many years, and I'd like to start with your overall perspective on how things have changed with prescription drugs, perhaps in some ways for the better, in some ways for the worse. Just wanted to get your overall perspective.
Well, I've been a pharmacist 37 years, and I've done everything you could do in pharmacy. We have a retail, a hybrid pharmacy with compounding, sterile, non-sterile, home health, hospice. I've done it all, everything probably but nuclear. And the changes I've seen is what drove me to run for Congress. Honestly, Mitchell, it's, when we started out with the pharmacy, it was a medicine shop 37 years ago. And when you see that people paid cash for their prescriptions back then, and when pharmacy benefit managers came onto the scene, they were supposed to help the plan sponsors make it easier to transition, to make formularies to save them money per se, because they sponsored their employees. But I remember when you would slide like a credit card machine and it said PCS on it, and it was triplicate, and you sent two forms in, you kept one, and that's how you got reimbursed. And it was just a fee for service. But now what has happened, the cost of medications have skyrocketed, and we now have a middleman. It's like I tell people, you have your pharmaceutical companies, and they birthed the child. It's called the PBM. Now the child has grown up and it's smacking its parents around. That's what we have when it comes to pharmacy benefit managers. And it's changed the landscape of what physicians and healthcare providers can prescribe, what they want to do for that patient. And it's almost like they're in they are trying to practice medicine without a license now. That's it in a nutshell, as how, the pharmacy world has changed over the years, and what I can do and what I can do for my patient, or what the insurance allows me to do. So there's a big gamut there from what it used to be like and what it's like today.
Right. And we'll get into PBMs in a little more depth momentarily, but also you've been a big proponent related to that of eliminating barriers to patient care. And that kind of all revolves around what you just mentioned.
Yes, absolutely. Having a pharmacy, an independent pharmacy like I have for years, you have patients who you'll have uninsured or underinsured patients. You have those on private insurance. Doesn't matter, whatever it takes for me to talk to that healthcare provider to get them the medication they need, is what I'll do. And one thing, there's a lot of things that's changed as far as what the healthcare system has done for these patients, like your 340B. You have many things of that sort, where a lot of independent pharmacies do that and give them their medications at a lower cost. But my goodness, it's one of these things where I've seen such a change over the years, where I would give it to the patient. If it's not covered, we'll get you an alternative that's feasible for you to pay for, or we'll get a prior approval for that, or we'll get them to change it for something that is covered. That's what we're supposed to do. I feel like the pharmacist is a triage. You have the physician or the healthcare provider, the patient, and the pharmacist. It's my job to send them in the best direction to get the best healthcare that they can get. And, because of that, Mitchell, I have a bill, it's an ECAPS bill. We have physician shortages now that we didn't have those physician shortages or nursing shortages when I became a pharmacist. We've seen that happen. We had a shortages of pharmacists when I first got out, and now we're overloaded because of the number of schools that have sprung up everywhere. But what we want to do is be able to help the healthcare providers, and ECAPS is a way to give us provider status. And that way we're able to help the Medicare population, which is an ever-growing population, and we can do Medicaid patients as well. So that's where my focus is right now, as far as what pharmacists can do to help in the scheme of healthcare is. Not to mention what we can do on the other end as far as their businesses, like I mentioned before with PBMs.
And then one of the things, as we have an aging population, a growing number of people obviously have prescriptions. And one of the things that we keep hearing about is the lack of transparency, that people just don't know exactly what they're paying for. And I wonder if you could kind of walk through some of your concerns related to that.
Remember in Congress when they passed surprise billing, they've really reinterpreted that so the patient would know up front what they were going to pay, and they've manipulated that bill from the intent of what that bill was. But when it comes to that middleman in the pharmacy world, your physician prescribes something, the pharmaceutical companies, in order to get on a formulary, they have to begin to play ball. They have to do rebates. And the non-transparency part comes in like, well, how much is that being rebated? What's that patient's copay? You'll have some plans that have 3 tiers of copay. And if your drug doesn't fall into the lowest tier, you may pay more in the second tier, and then you're really going to pay a lot in the third tier. And if it's not covered on any of those, then you have to go through that prior approval process. It's unconscionable for those patients. If you go through that process, how do they know what the copays are going to be? And honest to goodness, I've seen plans when they change it either in November, December, or in January. These patients are told when they buy and purchase the plan, well, your drugs are covered. And then they find out it's not covered, or if it is covered, the copay is higher. That's where there's no transparency. There's no transparency about what the rebate system is. Okay. And we got to put an end to that. And there are transparent PBMs out there. Let me just tell you now. And it's our job to say, wait a minute, you need to play ball like we told you you needed to. And a lot of states are implementing laws on the books in order for them to protect their independent pharmacies in their state. And we at the federal level have to give them guidelines to say, wait a minute, you can't steer patients to your vertically integrated pharmacies, things of that nature.
Yeah, one of the things that we've heard, and I know you're very familiar with this, where a patient goes to their doctor, the doctor says, this is really what you need. They say, okay, fine. And then they go in to get the prescription filled, and then somehow it gets shuttled over to a different product, or they say you can't use this one, or you have to try this one and find out that it doesn't work, perhaps.
Oh, absolutely. It's like you have to fail on certain medications in order to get the one the doctor really wants you on. And that doesn't help the patient outcome. I mean, for heaven's sake, some of these people, I've said this all along, and there's a lot of docs, if you've been in practice quite a while, they agree. Some of the older generics, they know the side effects of these drugs and they want to prescribe them, but that may not be on the formulary. They would end up having to pay cash for that, for the very reason they've negotiated prices with pharmaceutical companies that say, wait a minute, we want you to have this one. And it prohibits the other medications that probably would work from being on that formulary, and maybe that patient can't pay for that drug. There's a lot of patient steering. There's a lot of take it or leave it contracting. There's a lot of, you will pay us this, and in order to get on that formulary. That's not cool in anybody's mind, because the person who suffers the most is going to be that little patient. And that's where I, as a pharmacist, I would get involved and say, wait a minute, we need to change it to this. And you almost have to go get a copy of the formulary, if you can even get a formulary from a PBM. Even, there's so much I could say. I get overwhelmed, because we don't even hold contracts, independent pharmacies don't, if you have a PSAO that negotiates those for you. And it's like pulling teeth to even get a copy of the contract that they negotiated. I mean, it's pathetic. There is no transparency with this, with some of the PBMs, most of the PBMs.
Well, I know there's a lot of legislation out there, but let's dive into some of the legislation that you've supported, the Pharmacy Fight Back Act. What is the goal of the legislation, and can you talk to us a little bit about that?
Yes, it's very simple. You know, whenever you create something, the pharmacy benefit manager world is a complicated world. They really don't want you to know what's going on because if you could figure it out, you would fix it. But what this pharmacist fight back bill does, it absolutely prohibits patient steering. And when, you know, because you may be able to get it filled at your independent pharmacy the first time, maybe even two times, but then in order to get the preferred pricing, you have to have a mail order pharmacy, their mail order pharmacy send it to you. So we want to stop that. We want to make it a level playing field as far as what you're reimbursed. A lot of times, certain contracts say you have to dispense this drug, but you're going to get reimbursed less than what you paid for the drug. We want to stop that, and we want to put a system of reimbursement that's going to be fair to the independents, as well as maybe the plan sponsor would, you know, dispense a medication or what have you. And then the rebates, that all encompassing mystery shrouded rebate. 80% of that rebate that we find out what it is, that needs to be going to the patient. And we need a clear path for that to get to the patient to save them money because they're paying for the plan. And then 20% needs to be put into a little stockpile in case premiums or whatever goes up. It's not a complicated bill, Mitchell. It's very simple. And to work with the Democratic side, because this is a bipartisan issue, everybody has an independent pharmacy in their district that would benefit from this. And I've talked to, listen, I serve up myself to be able to talk to all these members. If they want me to do a Zoom call with their independent pharmacist, I am happy to do that. And I explain the legislation. They tell me the problems. It's like it compiles one on top of the other. And you know, if a state has good legislation on the books, then go copy it, states. You know, everybody's open to helping them get a handle on that. And Tennessee has had to revamp some of their PBM legislation 2 or 3 times, but they've got a good handle on it. Now the PBMs in Tennessee have to open their books up to the insurance commissioner if there's a question. So these guys, you know, we want to bring the price of medications down. This is one way to do it. We want to save money. We're 36 trillion in debt. Hey, people can't afford to put food on their table. When they have to decide whether they're going to eat or they're going to buy their medicine, we have a huge problem in this country.
And you mentioned the bipartisan nature of this. It does seem like there is a lot of support on both sides of the aisle. People just want to find out what the pricing is, have some clarity about it, and then perhaps lower the prices for people to get better access.
Yeah. You know, when the IRA was passed, who thought the government should have authority to price anything? And now they have authority to price a certain amount of drugs. And I don't think that's good. We need to repeal that. And it, there's simple ways to fix these problems. And like I said, you're taking a calculus problem and you're trying to reduce it to simple addition. And that's what we have to do with these PBMs. It's not like I want to go out and do away with the free market. That's not what I want to do at all. But when you have such vertical integration that the interim FTC report showed us, and I told Chair Khan, I said, look, I could have saved you 2 years and a lot of money if you'd have just listened to me up front. And here we are. Everything that we told them was happening, they found out. And that's just the interim report. And so when you have 6 PBMs doing filling 94% of the prescriptions, don't you think that's a problem? And the big 3 are filling 80%. It's a huge problem. And so what we want to do is just level the playing field so independent pharmacies can coexist with the chain pharmacies and all these mail order systems that are in place. We just want people to know what they're going to pay for their drug and how much it's going to cost their insurance plan, especially health plan sponsors that are self-insured.
Well, it's certainly something that affects everybody, and it's hard to argue with a lot of the things that you're saying about what people want in connection with transparency and clarity related to pricing. And the last thing I would ask is, are you optimistic that perhaps something, if not during the lame duck, can get through in the coming year?
Well, we're working on that now. I just talked to my healthcare policy advisor a few minutes ago, and we're trying to get some kind of healthcare legislation with some PBM points to it through the House. Now, there's the lower cost, more transparencies bill that we passed out of Energy and Commerce, which is the committee I sit on. It's sitting in the Senate. Now we'll have a new majority leader, and that'd be Senator Thune, and he is absolutely on our side as far as the PBM legislation, making the PBMs transparent. So there's a big chance that we'll get something done. Hopefully, if not by the end of the year, the first 100 days in the new administration. So that's what we're banking on, and I'm going to push it as hard as I can, because these independent pharmacies and these little patients deserve to know what they're paying, and they need to be able to survive. These pharmacies do, and they just want hope. And my message to them is, I want you to have hope, because I am beating up anybody and everybody I can to get them to open the books, to do business in the right way, and to level the playing field.
All right. Well, thank you very much. And we're going to leave it there. And I'd like to thank Congresswoman Diana Harshbarger with Tennessee's 1st District. I'm WTOP Capitol Hill correspondent Mitchell Miller, and thank you for taking part in the Healthcare Agenda, Real Policies for Real People, sponsored by Pharma, the Pharmaceutical Research and Manufacturers of America, on WTOP.com.